We are again. Hi, everyone. I'm Rachel, and a very warm welcome to your Midlands Analyst Network Huddle. For any new people, we hope you'll find these fortnightly huddles useful by sharing skills and learning from each other's knowledge and experience. But basically, this is an opportunity to hang out with like-minded people. There's more info about why we established the network and the role of these huddles in the files section of the Teams channel, if you can access that. And we're always looking to improve them, so do feedback via the Teams channel, or you can email me directly. And if you can share with me any great ideas you have about content, most welcome. And of course, we would very much like to know if you would like to contribute to any of the sessions. Anyway, thank you so much for coming today. As always, it's great to see you. And in today's huddle, the title is Economic Evaluation Sharing Session, an approach to demonstrating value locally. So we are again delighted to welcome our friends from the Health Economics Unit. Lisa, Will and Bea will be talking about that in a minute or two. But before I do that, there's a little bit of housekeeping, and I want to just make you aware that we are recording today's session. We tend to put the recordings automatically go onto the Teams channel. So if you can access the Teams channel, you can automatically access the recordings. And we put some of them on the website too. I'll be sharing slides after the session, and they're made available to me, so those who missed it can catch up later. So we're going to finish about 12 or just before, and if you have any questions or comments throughout, then please use the chat box if you can. You can shout out. Lisa has just said that's fine, and you are also able to use Menti for those of you who can't use the chat box. So there'll be the facility for everybody to contribute if they so desire. And as usual, these sessions are for you, and we like to keep them as informal but hopefully as informative as possible. So before I do hand over to Lisa and friends, if you could go to menti.com and type in the code 26082389, that would be very much appreciated. I'll just share my screen so we can see that on the screen as well. So that's 26082389. Because I always do it too quickly, and it does take time, even though you may have been there before. 26082389. Let's see if a few people have arrived in the land of the Menti. Yes, they have. Okay, that's excellent. So I was going to ask you a question. I'll ask you next time. Actually, of those who are on the call today, good morning, whoever that is. I was intrigued really to know what proportion of you are actually part of the Midlands Analyst Network, because I know people come to these huddles from different routes. So I'm going to ask that next time. Okay. So I was going to put a pic. I was thinking about holidays. Really, I was thinking about holidays. I was thinking about beaches, and I thought, you know, a nice beach would be just something to think about. Don't know how many holidays you've all got planned, but they seem to be happening now. It seems to be like a real thing that people are going on holiday to nice places. But I also wanted to mention the cricket. I mean, that's because my household is consumed by cricket at the moment, and that's lovely. So what we have here is a combination of both. We have this is a picture of yes, I need a holiday. I need a holiday too. And yeah, this is Barbados, and I know that they're not there quite yet, but I thought what a slick combo of cricket and holiday in a photo. So just a question for you before I hand over to Lisa. Really keen to know who's in the room. So very much appreciate it if you could just say what your job or your role is and your organisation, and we can just have a quick look to see who we've got in the room today. Do that? Is it working? Ah, here we go. Excellent. I seem to have things showing one at a time, which is fine for me because that's pretty much what I can cope with. So that's good. So we have public health covered, strategy unit, great. Mental Health Foundation Trust. I'm not 100% brilliant with acronyms. County Council. Oh, we have Governor. Great. Might know who that is. And the Health Economic Unit, of course. It's good to have NOTs covered. We're going to be having people from there in a few huddles time, and we're going to be looking at maternity. So in our last huddle, we said, what should we do more of? What's missing? And there was a few people who said maternity, so we're going to be covering that in a session, and we're going to be on the lookout for other people who do maternity. No, that's wrong. We're going to be looking for analysts who support maternity services or report on it. So we're struggling to find you all. That's been part of your role. Okay, that's great. So I'll just move that on to a question. So if you have any questions for Lisa and Will and B, you could just pop them here, pop them in the chat if you can, but you can pop them here, so at least we have somewhere where you can interact with Lisa. Okay, well I'm going to stop sharing my screen and I'm going to hand over to Lisa. Lisa, welcome.
Thanks very much, and thanks for having us. We're really excited to share, I guess, the work we do and our approach to some of the evaluations we do. I'm going to hand over to Will, who's going to introduce what we do in kind of the first few sections, and then B's going to talk, and then I'm going to finish off with a case study.
Great, thank you, Lisa. Good morning, everyone. So today's presentation is a sharing session on economic evaluations. But before we get started, we're going to do a quick round of introductions. So we're from the Health Economics Unit, which is an NHS organisation that supports health and care, arm's length bodies, charities, industry, and academia. And we provide expertise in health economics, population health management, and analytics. So we're currently 25 strong. We were founded quite recently in 2021, and we're a sister unit to the strategy unit, also hosted by Midlands and Lancashire Commissioning Support Unit. So my name's Will. I'm a senior health economist at the unit. Before I joined the HEU, I was a health economist in a private consultancy, focusing on cost effectiveness analysis. And before that, my degree was in physics. Lisa and B, do you want to give a quick introduction?
Do you want to go first, B?
Yeah. Hi, I'm Beatrice. I came to the UK around 5 years ago to do a master's in health economics and economics in the University of Sheffield. And I then moved to the strategy unit to become a healthcare analyst, and now I'm doing a secondment in the health economics unit as a health economist.
Thanks, and I'm Lisa Cummins. I'm also a health economist at the HEU. I probably describe myself as a analyst turned health economist. I worked for a number of years in financial strategy, pop health in North East London, and also worked on some national clinical programs. But then kind of transitioned to health economics after doing a part-time master's. Oh yeah.
Can we go to the next slide, please? Cool. So the aim of today's presentation is to discuss the rationale, approaches, and use cases for economic evaluations in healthcare. So there's going to be 4 sections to the presentation. So I'm going to start out by asking the question, what is economic evaluation in healthcare? I'm then going to ask, why perform economic evaluation in healthcare? Then I'm going to hand over to B, who's going to talk about the HEU's approach to economic evaluation. And then finally, Lisa's going to go over a case study example. So what is economic evaluation in healthcare? So a quite broad definition, economic evaluation typically involves assessing both the costs and effects of a health intervention, and often comparing these to the costs and effects of an alternative intervention. So this diagram at the bottom is really to convey that you can consider a really wide variety of costs and effects in an economic evaluation. So on the left, we have some of the effects we might typically consider. So we'd look at whether a technology is usable, if it has an impact on survival, if there are any associated adverse events. We might look at disease-specific effects. So for example, if we had a technology in osteoporosis, we could look at fracture rates. We'd look at how an intervention impacts on the quality of life of patients, if patients are satisfied with the technology. And we might also look at whether an intervention has an impact on health inequalities. And in terms of costs, we look at sort of direct acquisition costs, maintenance costs, whether there's a cost for infrastructure to support the intervention, if there are concomitant medications or interventions required, and then finally a quite broad category, healthcare resource usage. So many interventions affect how patients interact with the healthcare system in the short and long term. So we need to consider things like reductions in ED presentations or changes in the number of outpatient appointments. So through assessing those sorts of costs and effects, economic evaluations seek to answer two central questions. So the first question, is an intervention affordable? So to answer this question, we're looking at how an intervention would impact on the total costs in all of those different categories of providing healthcare for a population. And then the second question, is an intervention value for money? So here we're looking at what health benefit is generated for what cost, and how does this compare to alternative interventions? So just to introduce some terminology, the main types of evaluation that you'll see for the question of affordability is budget impact analysis. And the main types of evaluation you'll see for the question of value for money. Firstly, we have cost effectiveness analysis. So this produces the result called an ISA that you may have heard of, which is, it's a way of synthesizing different health effects into a generic measure called the QALY, and then looking at how much of that generic measure of benefit you can generate per unit cost you put into an intervention. And then secondly, there's the cost consequence analysis, which doesn't sort of try and synthesize effects. It produces separate effects, a sort of tableau of separate effects, and presents these alongside the cost of the intervention. So why perform economic evaluation in healthcare? So it's quite straightforward, really. The reason we perform economic evaluation in healthcare is to empower evidence-based decision-making in the context of finite available resources. So with finite available resource, firstly, you need to assess affordability to ensure that budgets aren't exceeded. But you also need to assess value for money to ensure that you're maximizing the health benefits you generate from your budget. So to maximize health benefit from a budget, it's not just a matter of choosing interventions that have the most health benefit. You have to look at interventions that have the most health benefit per unit cost. So for example, if you had an intervention that extends life by 10 years, but you can only afford to give it to one person, that's not going to generate as much total benefit as an intervention that extends life by 5 years that you can afford to give to 100 people. So some examples of decisions that you can inform through economic evaluation. On a local level, you might look to answer a question like, should a trust implement a risk stratifying algorithm to help manage patient wait list? And on a national level, you might answer a question like, should NHS England provide an expensive new medication for a rare type of cancer? So that's a bit of an overview of what economic evaluations are. And now I'm going to pass over to Bea to talk about the HU's approach to economic evaluations.
Thank you, Will. So before I jump into more content, could I ask you to type in the chat box, from 1 being none to 5 being loads, what experience do you have being involved in evaluation? So 1 is none and 5 is loads.
Do you just mean economic evaluation, Bea, or is it sort of like a broader, any evaluation?
Any.
Okay.
Just to assess the level of knowledge in the room. Stephen Wyatt. Yeah.
Yeah, I've heard of him.
Yeah, me too. So while people comment, can any Rachel or Stephen comment on the type of evaluations you do?
I've changed mine to a 3, which promotes Stephen. Tactics. Stephen, are you prepared?
On reflection, I think mine's probably an exaggeration as well. I think I should go back to a 3. But anyway, but it tends to be evaluation of specific services or policies in the NHS, and they occasionally have an economic component, but that economic component tends to be quite simplistic, I have to say, in my experience, the stuff I've been involved in. So we do a lot on really nailing down the activity consequences of service and policy interventions, but the economic stuff that I've been involved in, that tends to be an afterthought, a bit of an add-on, not probably thoroughly thought through in the study design, if that's helpful.
Yeah, the first question when we are evaluating technology program is whether it works, it doesn't, and then at the end of that kind of questioning, we would get more value for money type of questions. Janine, do you want to comment?
Not really. I've been out of the local system for a while now, but yeah, got quite involved in doing some economic evaluation work around the Better Care initiatives when they were being implemented across as a kind of partnership between local government and the NHS, looking at actually whether the interventions that have been put in place had actually delivered good outcomes for people and saved the system money. So this is looking at kind of things like falls diversion schemes and that kind of thing. So quite small level, but those things that are really difficult to measure. So particularly where the savings are in one part of where the cost is in one part of the system and the savings are in another.
Yeah. That's I'm gonna make a point on now transferring from CCGs to ICSs. Yeah. So Lisa is asking, what experience do your attendees have on providing data for evaluation or to demonstrate value for money?
So before people sort of respond to that, three people have put 2s. There are 3 2s on the Menti site. So some people have had some experience of evaluations. So what experience? I'm reading out loud now. This is terrible, isn't it? We'll have another 2.
For those 2s, I'm gonna make a brief overview, the slide that you can see at the moment.
Okay.
Yeah. So I can then jump into the content. So I'm gonna talk you through the approach that we take in the Health Economics Unit on economic evaluations. My area of expertise is in evaluating digital technologies. So when I'm referring to an assessment of an evaluation, in my head, I'm thinking of a technology that is implemented into the system. But this can apply to a program. It doesn't have to be a technology. So any project, we are consultancy based. So any project starts with a scoping. And the first client meeting would be to understand the technology, the stage of development of that technology, the stage of implementation at provider level, and then as a consequence, what type of evaluation do they need. And we would, after that meeting, we would write a proposal in which we would scope the whole project, which would be basically what this slide presents. A review on existing evidences, because we don't want to duplicate work that has already been done before, the type of evaluation, the pathway analysis that I'm going to briefly mention in a second. Then a logic model that will lead to producing a key set of metrics that we want to evaluate, then produce the evaluation, and then write the final report. And planning is key here, because in terms of timelines, we, as an analyst, is not only analyzing the data, but if you're deciding on the evaluation before everything, for example, a technology has been implemented in the system, we need to look at the follow-up of the metrics that the stakeholders want to look at. And also, one of the key points in evaluation is accessing to the data, because nowadays more clients are demanding real-world data, which might not be the data set you have access for. And these technologies might gather, these new technologies might gather their data in a different data set. So again, you would have to do a different data sharing agreement depending on the situation. And back to Janin's point, in terms of the perspective, we are starting to hear our clients not only want it, from the transition between CCUs to ICSs, they not only want to analyze the metrics that apply to them, but also they are starting to demand other outcome measures that are relevant for the whole system. So once we have done the scoping, the next step, we would be looking at the intervention. So in my case, the technology. So looking at the population demographic, looking at the levels of digital literacy and other components that might affect the usage of the app. We would also do a review of existing evidence related to this technology, and then we would produce a pathway mapping. And these maps are to understand what is the current practice, and then if the technology is introduced, what changes would happen in that current pathway. And you can gather that information from different methods, from the literature, implementation plans, if they're available from a pilot, and through a stakeholder engagement. And in terms of the logic model, next slide, please. A logic model is a visualization tool to monitor the process of change. So if input activities and outputs occur given this particular technology, then we would see some results. So in terms of inputs, an input can be a staff using this technology, the building in which all of this activity occurs, and that would lead to, for example, some decisions being taken within a specific technology, which will lead, for example, to numbers of patients being treated under this a specific technology we are looking at. And if all of that happens, then we should expect some result as a consequence. And we can classify that as outcomes, which are benefits directly linked to the technology or a program, and then impacts that are more long-term results of this intervention, which is not necessarily linked to the intervention per se. And yeah, so if we click in the next slide, please. And just to make sure that this exercise, this logic model exercise is to make clear about the interdependencies between the if and the then what is expected to happen. So one that's done, and we have a stakeholder engagement to make sure that our model is a reflection of what is happening in the system. We have come up as a result with key metrics to identify and then as a consequence, the data sources that we need to look at. And again, we don't want to make work on things that have already been done before. So the first thing to do is looking at the gaps in data that are well, look at the data first that is currently available in terms of evidence, and then work on how are we gonna manage to get this evidence in gaps. And then when we have a think about this whole structure, the result would be an evaluation framework in which we would have developed the approach, the methodology, the analysis, and the modeling plan. And the methodology, now that we are in an analytics crowd, it could be, for example, propensity score matching or other cohort study designs. And once we have created the evaluation framework, that's when we need to start gathering evidences. The first goal would be going to the literature, because again, we don't want to spend time doing something that has already done before. So this can be done by doing systematic literature reviews or from the literature, looking at results from meta-analysis. And then analysts. So I'm really biased because I'm an analyst myself, but then you would look mostly at the data. And as I said, now in the last around 10 to 20 years, more clients are demanding real world data. So we could have access to data from provider, from the technology, SaaS, ONS, and others to populate the evaluation that we have defined upfront. And of course, you can also do qualitative analysis, but I'm biased. For me, quality data goes first. So yeah, you could also do other components of the evaluation, which would incorporate focus groups, interviews, and other type of qualitative study designs. And once that's done, again, one of the key milestones is accessing the data and looking at DPAA and other things related to data, which, as you know, it can take months. And yeah, so once we have analyzed the data, then we would summarize the results into a report that would be shared with the client. So I'm gonna hand over to Lisa. If you have any questions, please ask me at the end of the presentation.
Thanks, Bea. Thanks, Will. Right, I'm going to now present an example of a recent evaluation that we did in the team. What I'm going to touch on, though, instead of kind of going into too much detail about the findings and stuff like that, I'm going to more touch on kind of the challenges and limitations that we face and that are common, I guess, across these types of evaluations that we do. And also I'll touch on some of the methods as well, because I'm just conscious that we've probably got quite a lot of analysts on the call. So try and make it some kind of relevant to the work you do. So this, and actually just to say at the outset, this is probably more in line with the type of evaluation that you mentioned, Steve. It's more of an impact evaluation with a bit of a costing element, and I'll explain why that was the case as well as we go through. So MaST it's basically a decision support tool that uses predictive analytics, and it was implemented in Mersey Care Foundation Trust across different services. And the aim really was to try to help staff to better manage patient care, or kind of better manage caseload, I guess, in a sense, to help. It was able to, like, for example, flag if a person may be at risk of experiencing a mental health crisis, and it did that kind of using data from different sources. Sorry, now I'm having to navigate doing slides and talking at the same time, but I can do it. In the work we do, we usually work collaboratively. So for this particular project, here's us, we're the health economics unit. So we would have the health economics team, we would have drawn in support from some of our colleagues in the data analytics team as we were developing our methods and our approach. The evaluation itself was funded by the Innovation Agency. So this is an AHSN, so an academic health science network, and it's operates in the Northwest Coast. We often work with HSNs on similar projects with SMEs to evaluate impact and kind of try and demonstrate the potential benefits of new technologies. We also worked quite closely with the team who had developed MaST, so in particular the director Caroline, clinical lead as well, on the project, and the data and analytics team as well at MaST were really kind of instrumental in the work that we did, or in enabling us to do the work that we were doing. Sorry, it's probably a better description. And then we worked kind of indirectly then with Merseycare through MaST and the Innovation Agency, and we were able to use some of their data as well for the evaluation. We also worked then as well with academics to validate our work. For this project, we worked with a professor at Leeds who quality assured our approach and provided some advice on our methods. And we also worked with Cummins as well to disseminate our findings. So the aims and objectives of the evaluation were to examine the impact of MaST on service user flow, also to see if it improves management of mental health crises in the community, and also to assess whether or not it had impact on resource use and cost saving, and then kind of lastly to look at quality and safety measure indicators. So MaST, the team at MaST had kind of collected data and on a number of quality and safety performance measures, which were defined with the services as well. So we looked at the impact of those over time. I'm going to touch here on the key findings, but I won't go into too much detail at this point, but I can touch on it again later on, and I can take questions as well. So our key findings were that service use fell over time and varied by age, gender and ethnicity. Mental health crisis rates also fell. There was evidence that there were some cost savings, and as well that MaST appeared to help staff to better manage care. But because of the constraints and some of the challenges we faced, it just wasn't possible to determine that these changes were actually caused by MaST alone. So broadly, this is the approach that we took. It's slightly different from what we presented because it's tailored to what we did for this project. I'm not going to go into it here again because it would probably just be repeating a lot of what B said. But what I will just say at this point is that it's very different. Well, kind of, it's not a nice, neat path to get from scoping to reporting. Sometimes it actually feels more like an obstacle course. You feel like you've kind of faced one challenge and you overcome it, and then once you kind of get over that wall, there's something else that you need to crawl through or jump over. But I guess that's what makes our work interesting as well, and allows us to kind of come up with more creative approaches to what we do. I'll also touch on the quantitative analysis that we did. So we did an exploratory analysis, descriptive and trend analysis, and then we did a mixed effects model as well. We hadn't originally planned to do a mixed effects model, but that was one of the constraints we came up against. So I'm going to touch on that and I can move to the next slide. So what I've done is I've kind of overlaid some of the challenges that we came up against throughout the project. The first one, which is common across the type of work we do at HSNs and SMEs, is often budget constraints. So there's usually a small pot of money, maybe around 30 to 50 grand maybe is what we kind of would be commissioned to do this type of work. To do a full-scale evaluation alongside an economic evaluation would actually require a lot more days. So what we're often have to do is kind of do more of a condensed version of what's possible. So we think about the ideal approach and then we work with the client to kind of refine what's possible. Often as well, we're working on rapid evaluations. So this this particular evaluation was, I think, I can't remember exactly the length of time. I think we had 6 to 7 months to deliver it as well. But we had a short time frame kind of from when the short time frame from when it was introduced to kind of when it was evaluated, because lots of the work we do, we need to support quicker decision making, so that also kind of has another added challenge to it. The kind of next series of problems we hit as we kind of moved through the process was we discovered that MaST was introduced at different months, at different time periods. Also, we identified that there was actually wider system changes happening. So there was the introduction of crisis resolution and home treatment pathway. And really the aim of this pathway is to reduce service use in hospital and shift it into the community. So one of our key outcomes was impact on resource use. So you can kind of get an idea here of what that might mean for the findings of our evaluation. And then also it was implemented with a few months before COVID. So really quite a big chunk of our post-intervention period was impacted by local and national lockdowns. Then as we kind of moved on and we got access to the data, we identified kind of data quality issues. So our pre-intervention period was actually quite cut short by quite a lot. I think we had maybe 6 to 7 months pre-intervention data that was of good quality. And this was due to system change and also a move to using the community services data set, which improved data quality. Another challenge we faced around data was small numbers in some services. And this impacted kind of our analysis of crisis hospital admissions. And then the final big challenge was, or big limitation, I guess, of our work was being unable to determine the causal link between MaST and the key outcomes that we'd identified at the beginning of the project. So what I'm going to do now is kind of touch on some of the things that we would do internally that we've learned, I guess, from doing these types of evaluations to try and manage any of the potential risks or potential risks, I guess, or issues that may arise out of these challenges and constraints that we face along the way. The first one really is key, is just to develop a good working relationship with the client. By client, I mean the innovation agency and as well the SME that we were working with. And also understanding the decision problem, the wider context. So we usually kind of take a broad approach to understanding what the problem is, what's the key challenge the technology itself is looking to address, thinking then broadly about, okay, what's the best option or the best approach to evaluation and economic evaluation. But then also acknowledging the constraints that we have in terms of time and budget. So what we try and do is identify those gaps where the evidence is lacking, and then we prioritise what's kind of possible with our resources. We communicate that quite early on to the client as well, so they're kind of not at the end of it, if we can't demonstrate whether something was cost effective or another thing, they understand why we haven't been able to do that. Also key is understanding what the context, that wider context, and by doing that exercise at the start, that pathway mapping exercise in particular, and through discussions with the clinical lead, we were able to identify that there was actually a whole lot more system changes happening in the background, and that's ultimately then as well going to have an impact on our findings. And then the second point here is understand what decisions will be made with the findings, and this kind of helps us focus then our minds, I guess, as we carry out the evaluation and thinking about the end product in terms of reporting and stuff, so that we can try and generate that evidence that the people need to need to make by doing these rapid type evaluations. And here, kind of at this point around data as well is key. So building good relationships with analysts, I found, is really important, especially when you're using local data. As you know, if you join a new team, or if you move to a new ICS or CG, or you trust, there's quirks in the data that you can only know once you've kind of been in it for a while, I guess. So it was really useful having a good relationship with the analysts in this project, because it helped us identify quickly what those issues were with the data, and whether or not actually were they due to resource changes, were they due to the new data capture system, for example. And also having input on the methodology, and also having a backup approach as well, I think, is important. Because we had, for this analysis, we had initially planned to do a my mind's gone blank, an interrupted time series analysis, but when we got the data, then we realized that wasn't possible. So that's why we decided to do the mixed effects model, was to try and control for the introduction of the intervention at different time points. We also tried to control for the impact of COVID as well, but because of the short time frame before and after introduction, it just made it very difficult. Ultimately, our results actually were statistically insignificant. We weren't able to say that MaST caused a change in hospital admissions, for example. But we did do some additional descriptive analysis and some trend analysis, which the client found useful. But yeah, that's kind of an overview of some of the challenges we faced and some of the things we do to overcome any kind of like bad impacts, I guess, or negative impacts is probably a better way of describing that. Yeah, does anyone have any kind of questions at this point?
Not so much a question, but a sort of a observation. It does feel a bit more like art sometimes, doesn't it? When you just try to, you have a nice neat diagram too, because that's the plan. The reality of it is you have to, well, all of the things that you've been describing, I can just see that being that's pretty much what it's like in real life. But those are the things that you face. Those are the things that you're going to have to put measures in place to deal with and everything. And no, that's really useful. That's great. Very interesting, actually. Thank you, everybody, for what you've shared so far. We do have a question here, which is kind of a more general question for you, Lisa, probably, or any of you really, about other examples. And the question is, do you have any useful examples looking at preventative services and/or with the impact of the wider determinants of health? So this is a bit PHM, this is a bit you, this is a bit of everything. Have you been involved with anything like that? Is it something that you can think of examples that exist out there?
I'm just trying to think now. I'm just thinking if anyone else on the team is on the call, maybe Jack, because he's doing some work on a new method that they're looking to introduce called STAR. Which would be looking at the reallocation of, or potential benefits of reallocating resources kind of from downstream services to preventative measures. It kind of takes a holistic view of the pathway.
Yeah. That does sound that it would fit the bill, sort of thing. Yeah, I think I might I think that'd be very useful content for Huddle, actually. I'm pretty sure it's on the list.
Yeah, I think Jack is going to come and do that. But I guess just broadly speaking, in terms of evaluating any intervention, whether it's at the start of the pathway, it's a preventative, a new model of care that impacts prevention, or a new intervention that kind of prevents a patient having adverse effects or whatever it may be, the approach would generally be the same. Mm-hmm. It's at that kind of logic modelling pathway analysis part where you can really identify your potential impacts. And then at the end point, when you're doing your analysis, you could do some subgroup analysis as well and look to see if the impact potentially varies for people living in different deprivation quintiles or different age groups and stuff like that. There's a number of different methods you could apply.
Okay, and that's very helpful.
Anybody else want to come in from the team on that one?
Wayne has his hand up. Where are you, Wayne?
Maybe another example is looking at we evaluated the impact of risk algorithm implemented in primary care. So we have been looking at firstly validating an algorithm, identifying people at risk of HF.
Okay.
And then the next step to that will be how do we then implement that algorithm and what's the impact on the system of using an algorithm.
You're a little low, Wayne.
Yeah, so hopefully we'd be able to feedback or maybe present on that in a follow-up session.
Yeah, no, that sounds good. Sorry, was that heart failure? Did you say, Wayne? I think
Yes,
I might have missed it. Oh, right. Okay. No, that sounds interesting, because of course these preventative measures or services typically the lag between the impact and the effect is, well, it could be many years. So this is public health for you, isn't it, Janine? So it's quite, it can typically be either a long study or it can be quite difficult to demonstrate within the timescales that people want answers, which is another thing. That's another environment which you touched on. People tend to want answers quite quickly, and commissioning a sort of a longer piece of work is obviously it does happen, and it needs to happen for the robust results, but people also want sort of short-term answers as well. Okay, no, that's been great. Thank you. It's great to meet you all. I already know a couple of you, but I don't think I met well before. If anybody doesn't, if there's nothing else for anybody, no further questions. Oh, there is one actually. Just one further question, and then I've just got a couple of things to finish off with. Would modelling preventative work, public health, with perspective of a whole system be suitable for a future session? Ah, well, that's almost like one for me. I'll just say yes. Yes, it would.
Yeah, exactly. I forgot to mention one thing actually, which was perspective, and often the work we do is from the kind of a local commissioning perspective or a national commissioning perspective. We haven't, well, so far in the team, potentially in Wayne's work, before they set up the health economics unit, we could have done some wider stuff, but the challenge with doing kind of a wider perspective economic evaluation is drawing in, is finding the relevant data and information to really kind of estimate the impact beyond.
Totally appreciate that. Okay, well that's great. I mean, it does feel like there are more sessions here, and I think it's like an incredibly useful topic that we need to cover again. Okay, well thanks very much, guys. I'm just going to move on to a couple of slides, which I'm just going to just give a little bit of an update on the next couple of huddles that are coming up. So what have we got coming up next? So the Health Foundation are coming next, and Fiona Grimm from their Networked Data Lab is going to be talking to us about open analytics. I don't know why I've got a question mark there. She is. And then we have David Callahan from Strategy Unit. He's going to talk to us about the ICS intelligence function guidance. So I think that's a hot topic at the moment. If people haven't seen it, there you go. That's a perfect introduction to you for that. And then we've got another health economics unit appearance in the shape of the wonderful shape and form of Andy Orlowski, and he's going to be talking about PHM impactability. And back by popular request, that's not true actually, we haven't covered maternity, and it was suggested it would be a topic that would be of interest and that needed covering as well. So we're going to be looking at it in a few huddles time. And one of the main emphases, focus of that is building links with other analysts who are involved in maternity, it says there. And then just before we finish, just an update on training and development. So do see the prospectus on the website for details of all of the training and development opportunities that are here at the moment, but in particular those that are live or about to become live is the theory of constraints for patient flow. Now this is a one-day course, so with 3 separate dates. I'm taking registrations at the moment. Alex Knight is the trainer for that, and he's an expert in this area. So he's not basing it on his book, but actually, if you are an attendee at one of these courses, you get his book. This comes with it, with the package. But this I think this is excellent training. It may the focus is probably more healthcare setting, so because we're talking about patient flow, but I think the learning, the skills would be generalizable, and I just think it'd be really interesting for people beyond those who just work in a hospital or wider healthcare setting. And then we've got something, just back to that theory of constraints once, that isn't actually just for analysts. So I'm showing it here because it is for analysts, but it's also for the prerequisites in terms of sort of technical skills are sort of fairly low for that. So it's really just those people who are interested in that topic. And then I say, so moving on to these communication skills series. So we've got Campus PR, who are communications experts. They are delivering with a course for us. So this is in the shape of 3 half-day workshops plus mentoring. And I think this is going to be an excellent course. I'm really excited by this. So, but you need to be careful about the content of it. It'll be up on the website tomorrow. The details of it, it'll be opening tomorrow. So it's just making sure that you look at the content of it, just to make sure it's for you. And I think that would be a really great course for some people. And they're really nice to work with. They're really lovely people as well. So basically we're working on the 22-23 training and development program. Janine and I are meeting regularly on that at the moment. So we will be reaching out to you to make sure that we are getting the balance right in terms of the topics we cover, the training we're covering, and we'll make sure that it sits well with the intelligence guidance and everything that you need to be achieving in your different settings. So I think that is it, everybody. We have 4 minutes to go, and that is just marvelous for you. And thank you very much for coming, everybody. And I'll see you again in a couple of weeks. And thanks Will, B, and Lisa.
Thank you.
See you soon. Bye.
Bye.
Bye.